It's my pleasure to co-chair this session with my friend Sergio, Berti from Italy. It's going to be a nice session about emerging indications. So we have talked a lot about patient profiles, which patient would be a good candidate for LA closure. There are some emerging indications that we are addressing now within this session. There will be some polls also that we will.
I think yes, we can start with the. We have one poll.
The first poll, maybe. So just to say that we will have the poll before and after the talk of Dr. Stiermaier. So let's start with this one. So. What is your preference approach for stroke prevention in hemodialysis patients with AF? So vitamin K antagonist, DOAC, low molecular weight heparin, LA closure, or individualized decision?
Yes, individualized decision, yes, the personalized medicine approach.
So it seems already that there's a controversial aspect of this indication.
Because it's a very unexplored territory.
Okay.
Okay, the treatment should be based on an individualized decision. Okay, can we move to the next poll? In the dialysis patient with atrial fibrillation prior measured bleeding, should LAAC closure be preferred over anticoagulant?
So it's half and half almost. Okay.
Yes, routinely.
And there was
okay.
There was a last poll, I think. Yeah, there was like 3 questions. Can we see the last one? So the patient with the end-stage renal disease with a CHA VASC of more than 2, but no prior bleeding, would you consider LA closure? So it's really like
the consensus is.
It's not clear.
Not balanced. Not balanced.
Okay. So it's our pleasure to invite the first speaker from the team of Lübeck. That's Thomas Stiermaier.
Your microphone.
Yeah, you have the microphone there. So he's going to address the LA closure in dialysis patients.
Yes, Thomas, after your presentation, we will see the impact of your presentation on the opinions of the colleagues.
Yeah, but I just realized that we forgot one option, inclusion in a clinical trial.
Okay.
So I'm very happy to be here and to contribute to this important meeting. Also, you might have heard of the German airline strike. So my trip started at 4 a.m. and was a bit like oral anticoagulation in hemodialysis patients, a bit of chaos and a lot of uncertainty. But as you all know, you know the numbers that atrial fibrillation is increasing. We have a lot of patients, it's increasing with age. And the incidence is even higher in the end-stage renal disease cohort, with an increasing incidence of atrial fibrillation, with a decrease in eGFR. And these patients are also at an extremely high risk of embolic events. Also with a further decrease of renal function, the strokes and embolic events increase. But as you can see in this analysis, the amount of patients of end-stage renal disease patients with sufficient oral anticoagulation is low, at least in the warfarin era, where only 1 out of 3 had sufficient anticoagulation or had anticoagulation. And that's probably because of the extremely high bleeding risk in this cohort, because of high comorbidity burden, and we do not have DOACs or vitamin K antagonists that are on label in this indication. And if you look at the outcome data comparing those patients on warfarin to that patient population who did not receive anticoagulation in the warfarin area, you see that the stroke hospitalization rate is similar in both groups. So the question is warfarin really effective in this population? And of course, you have these increased bleeding rates in the patients who receive warfarin. Of course, today we would prefer DOACs, but as you all know, they are contraindicated in hemodialysis patients and in end-stage renal disease. But we do have some data that compare apixaban to warfarin, like this US Medicare database with more than 25,000 patients with end-stage renal disease. And after building a matched cohort, you can see similar events of stroke or embolic events, but again, warfarin is not really good at preventing strokes in these patients. And you can see a lower bleeding rate if you use apixaban compared to warfarin. And we also have two randomized trials I will show you now, and you can see on these trials that it's really difficult to perform randomized trials in this patient population because both trials have been terminated early after enrollment of only a subset of patients than originally planned. Renal EF randomized 154 patients, it's about 20% of the targeted population, and compared apixaban to warfarin on chronic hemodialysis patients. And of course, this small subset of patients doesn't provide sufficient data, but as you can see, the also bleeding rates were similar in both cohorts. And what is really striking, we have a bleeding rate of 25 versus 31% within 12 months. So 1 out of 3 to 4 patients experiences bleeding, and the stroke rate is 3%. So altogether, we have a 10-fold higher bleeding risk in these patients compared to the embolic risk, and we also have high one-year mortality rates with 1 out of 4 patients dying during this study. The second trial, Exadia AF, also terminated early. Again, 97 patients in 39 centers in 5 years. So if you calculate that, it's not a lot of patients. And they compared apixaban 2.5 versus vitamin K antagonists in chronic hemodialysis patients. And again, there is not a lot we can derive from this data. Low stroke rate, high bleeding rate, and high all-cause mortality. So the current situation with oral anticoagulation hemodialysis is we have an extremely high-risk population. We do not have reliable data to guide our clinical practice, and we do not have sufficient guideline recommendations. There are some ongoing trials, but I'm very pessimistic that we will get sufficient data on DOAC soon. And we have various off-label treatment regimes. So some physicians use vitamin K antagonists, some use DOACs in full dose, DOACs in low dose, low molecular weight heparin, or just do nothing at all, or just do low molecular weight heparin on dialysis-free days. So some call it chaos. We have chaos in the management of these patients. And of course, LAAC could be the answer, as you know that most thrombi originate from the left atrial appendage, but there are several aspects that we should consider. We have these extremely high mortality rates, probably not related to embolic events. We have this high bleeding risk, which will probably also be high if you give dual antiplatelet therapy or even SAPT. And we have probably a higher procedural risk and a high comorbidity burden in these patients. And do we have data? There are several registries that compared LAA closure to standard of care, but we do not have any randomized controlled data, and I think the most reliable publications in this field is probably this analysis comparing LAA closure in CKD versus non-CKD patients, and it shows a similar efficacy but a higher rate of acute kidney injury and also bleedings in hospital and in the long term in the CKD group. And we also see this extremely high event rates, also mortality rates in the long term, probably because of the bleeding risk of these patients. And one recent publication, which is quite nice in Czech Interventions, nearly 15,000 patients with end-stage renal disease, and it's from US registry, and they were treated with warfarin, LAA closure, or apixaban, and they built matched pairs, and as you can see, this is quite promising for LAA closure. LAA closure is the reference, and it performed better compared to apixaban and warfarin in terms of the primary endpoint, which was stroke or systemic embolism, bleeding, and all-cause mortality. But again, even in the LAA closure group, we have 42% event rate within, in median 1 year in the composite outcome, and we have a 19% bleeding rate, which is really, really high. So we need a randomized trial, and that's where the LAA kidney trial comes into play. It's an investigator-initiated trial which we are coordinating from our center in Lübeck. It's funded by a grant by Adel, and we randomize patients with an end-stage kidney disease defined as an eGFR below 15 and atrial fibrillation with an indication for oral anticoagulation, and it's a one-to-one randomization to LAA closure or best medical care, and some say we compare LAA closure to chaos because best medical care is actually everything that I showed before. The primary endpoint is a composite of stroke, systemic embolism, cardiovascular or unexplained death, and major bleeding. It's actually the same as in the Closure IF trial. And we need to randomize 272 patients, and it's an event-driven non-inferiority design. I think the inclusion criteria are quite clear. It's an all-comer trial in the end-stage renal disease cohort, and so far we have 185 patients randomized. That's 68% of the targeted population. But you can see the randomization, the recruitment rates are quite very flatter than we want them to be, so we are happy that Adel and his colleagues in Belgium will join us soon, so we can get the remaining patients. But you remember the trials I showed before. We already have more patients in this trial than the other two randomized trials could contribute. So I would like to sum up that stroke prevention in end-stage renal disease is a dilemma. We have an extremely high-risk population. If you thought Closure IF was high risk, there's even more. LAAC could be an alternative, but we need clinical data, which we get when we finish the LAA kidney trial. Thanks.
Thank you, Thomas. Now we repeat the polls, so we check your ability to convince the audience that LAA is a good option. Okay, can we have the first again? Yes.
Okay, we could stop here.
After the pause, I have a question for you regarding this point. Okay. Okay, 60%, 63 individualized decision.
It's pretty much the same as before, isn't it?
Yeah. And then there was the last one. There was the last.
Okay. Do the next.
Can we see the next?
Wait.
Or we just wait?
Okay. 46 versus 41.
So it's on
Okay, the
balance
next.
again.
Oh, not finished.
And maybe the last question. Yeah, it's a little tendency for selecting patients. And there was a last question, I think. So patient with more chance of at least 2, but no prior bleeding, still there is like a small consensus that we should go for LA closure. Maybe...
Thomas, on the basis of the data you showed, it seems that the dicumarolic are not effective in prevent ischemic event, or is less effective to prevent ischemic event, but the rate of bleeding is very high, and the situation is not better for the DOAC because the bleeding is extremely high. So intuitively the LAAC closure seems a good option. That's correct, but the question is, and I want to involve Carsten in the discussion, we are at risk to fall in the closure AF area. So patient very, very sick. So what is the balance?
Yeah, you're right, but the problem is that we also have a 20% bleeding risk in the LAAC closure arm in the last study that I showed, so we have to think about how we manage the patients after LAAC closure. I think this is a point of discussion. And patient selection, of course, we designed an all-comer cohort trial, but after closure F, one could think about selecting the patients more like an age cutoff, but we have to get this data from closure F first, and I think it will be too late for the LAAC kidney trial, but I do agree that probably the high-risk 80-plus patient with a lot of comorbidity will probably not benefit from LAAC closure.
Let's ask someone in the audience, or Carsten, or I can ask the question to you, Carsten. If you have that kind of patient, and you in some way you calculate the mortality, and the mortality for this specific patient is 25%, end-stage renal disease, do you go for LAAC closure based on your data or not?
He randomizes.
Right. So we randomize, and it's a 1-year mortality is 25% in these patients. So that tells you something, right? But so before closure, we thought it's a really great idea, and it's a new indication. Right now, I'm more skeptical, but yeah, of course, everybody goes into the trial.
But I think we all have different opinions about what to do, but I think the only answer will be from a randomized clinical trial. Otherwise, we'll always get stuck with we don't know exactly what to do in those cases.
Right, and we get a lot of data also in the control group, what is done in these patients, and what is the best way probably if you do it conservatively.
Yeah, Philippe?
No, we don't have randomized data. We need more data from the registries. As we discussed this morning, this afternoon, with Jim, we need large numbers because these patients are really not the same. They are high risk for thrombosis, high risk for bleeding, contraindicated to DOAC, and they have a higher risk of stroke. So I mean, it's really a very specific population, and we don't know the best option. So I run for the individualized strategy for this reason.
I would be interested because we just discussed it a little bit. I mean, my major concern would be they might benefit from bleeding, but you have the device in place and they may have a high risk for DRT. So how to treat this, how to prevent the patients from DRT. So in your study, what is your therapeutic regime after?
So the recommended regime was 3 months of dual antiplatelet therapy, and it can be shortened to 6 weeks, and we recommend now to do it as short as possible, to 6 weeks dual antiplatelet therapy. And if there is an indication for aspirin, then they receive aspirin afterwards, and if there is no indication, then they don't have anything at all after 6 weeks.
And do you do, 6 weeks is a very short time frame. We know that DRT occurring later in many of the cases. So do you intend to do a closer imaging follow-up in these patients?
In our center, we have 2 TE follow-ups after 3 and 12 months, but we do not recommend this or do not ask for this in the study because we know that some centers can't do that.
And if you see DRT in those patients, what is your treatment strategy for that?
The first one is low-dose apixaban. A control after 4 weeks, and if it's gone, we are fine. Then the question is, we try again to remove apixaban, of course, because of the bleeding risk, but then it's individualized and also some kind of...
Adel, we have time for 2 short questions.
Yeah, but the question here from Martin.
So one comment, I think it's great that there's a study ongoing that will recruit as many patients as possible, but for the time being, I think there's one thing that is missing in the discussion, and that is the fact that if you ask the nephrologists, they don't put patients on hemodialysis, on anticoagulation or low molecular weight heparins if they have AF. They only put those patients on anticoagulation if they have an extremely high risk, and that is if they had previous stroke. So for the time being, I think we can already concentrate or focus on these patients that had previous stroke, because in those patients the embolic risk, the thromboembolic risk, is much higher than the bleeding risk, because you need to have a higher thromboembolic risk to overcome the downsides of the bleeding. So in the patients that we want to anticoagulate or offer alternative therapy, LAA closure, or those with extreme high risk for the time being, but hopefully you can expand that population to not only those patients with previous stroke and having end-stage renal disease.
I agree, but and I also agree to the point that the nephrologists use this scheme, but there are no data for it.
Sorry, there are not?
There are no data for it. There are no studies supporting it.
Okay, very short.
Short question. Why DAPT and no, let's say, reduced dose of apixaban? You have shown that apixaban is not worse?
Yeah, because we started a study about 4 years ago, and it was the state-of-the-art treatment for after LAA closure by that time. So maybe we would change it if we designed the study today.
Okay, thank you, Thomas. Congratulations. Excellent presentation, excellent discussion. Okay, we move to the next presentations. We're going to address another very specific situation. Patient that despite optimal medical therapy experience stroke. I invite Gavino Casu for the speech, and the presentation of Lorenz is close, so we will do a single discussion at the end of the presentations.
Good afternoon, dear colleagues. First of all, thank you very much for inviting me this meeting. So, my disclosure. So, atrial fibrillation is the most common arrhythmia in general population, 1-2% to general population, and is responsible to a high risk of stroke. Direct oral anticoagulation are recommended to reduce the risk. In this database, standard dose of direct oral anticoagulant were associated with low event stroke and cardioembolic and systemic embolic and cardiovascular death. Related to the safety, standard dose of direct anticoagulant therapy were associated with low risk of the major bleeding, fatal bleeding and hemorrhagic stroke, but a higher risk of gastrointestinal bleeding. So, direct anticoagulant reduce stroke, but stroke can occur despite oral anticoagulation therapy. The rate reported in different trials from 2% to 30%. This represents a significant clinical challenge in patients' management. Several mechanisms are proposed to explain the occurrence of the stroke despite oral anticoagulation, atrial fibrillation unrelated stroke, poor adherence or clinical inertia, inappropriate reduced dose anticoagulation, and finally, true oral anticoagulation failure. But this mechanism is very complex in more patients. No one single mechanism. Often the mechanism is not understood, very, very complex. First, competing mechanism might lead to ischemic stroke, large arterial atherosclerosis, small vessel disease, coagulopathy and hypercoagulability state, such as cancer, or no-atrial-related cardioembolic source. In this study, the etiology of stroke despite anticoagulation may be divided in three main mechanisms. Competing mechanism, large artery 60%, and small vessel disease 26%. The other, insufficient anticoagulation, cardioembolic despite sufficient anticoagulation. Another point, very important, is a poor adherence to direct anticoagulant therapy. This therapy offers many advantages with respect to warfarin, but not always this advantage translates into good adherence. In fact, in this study, only 66% of patients in therapy with direct anticoagulant therapy achieve a good adherence. When facing patients with stroke despite anticoagulation therapy, the main key is understand the exact mechanism of the stroke to guide secondary prevention. The workflow can be divided into three main groups. The first identify mechanism, competitive mechanism, and it's very important to choose the brain imaging like MRI could help us to understand or to distinguish the cardioembolic pattern, large atherosclerosis artery, and multivessel disease. In the context of the large atherosclerosis disease, we needed to use some technical like CT scan, echo Doppler, and MRI angiography. And we need further investigation to exclude other mechanisms of cardioembolic or testing, laboratory testing for hypercoagulability or vasculitis. And in second, poor adherence to understand if the patients give a good adherence to the therapy, adequate therapy, or drug-drug or drug-food interaction. And finally, we can be considered true anticoagulant failure, and in this case, we need to exclude the thrombus in left atrial appendage. So, when we move into the secondary prevention, the question is, what is the best strategy for these patients? Continuous oral anticoagulant therapy, switch to another anticoagulant therapy, or adding antiplatelet, or rhythm control, or left atrial appendage occlusion with or without oral anticoagulation therapy. We don't have strong evidence to a routine switch to another anticoagulant therapy. And in this context, switching give any benefit, but increase the risk. And adding an antiplatelet therapy increase the bleeding risk, but don't reduce the risk of stroke. In a renal extended study, 42% of patients continued the same oral anticoagulant therapy, and 39% switched to another coagulant therapy. And the adding of antiplatelet therapy gives an increase of bleeding risk. So, is it time to consider left atrial appendage occlusion in this context? In my opinion, yes. In this international surveillance study, we studied 95 patients with stroke with a 2 oral anticoagulant failure. These patients, we performed left atrial appendage occlusion, and we find only 1% of the periprocedural complication, and 2 years of clinical follow-up, we find 4% of ischemic stroke and 3% for cardiovascular death. So this is my take-home message. Stroke, despite all anticoagulation, identify a very high-risk population with a significant residual risk of recurrence. Not all events reflect true cardioembolic failure. An alternative mechanism must be considered. Switching or modifying oral anticoagulant therapy is insufficient to reduce the risk of stroke. A mechanism-oriented diagnostic workup is essential after stroke in oral anticoagulation therapy. A mechanism-oriented diagnostic workup is essential after stroke on our oral anticoagulation therapy. Left atrial appendage occlusion represents a promising strategy in selected patients with true oral anticoagulant failure, and stroke, despite oral anticoagulation therapy, remain in unmet clinical need, requiring further recommended evidence. Thank you.
Great talk. Thank you very much. We keep the discussion after the talk. So it's my pleasure now to introduce Lorenz Räber, a friend, colleague from the ELAACC, from other purposes. Lorenz is going to address the LAAC in extreme stroke risk subgroups. And we will keep like 15 minutes of discussion after the 2 talks.
Yeah, thank you very much. So the pathophysiological considerations were already nicely presented. And I will add what is going on in the field currently in terms of generation of evidence. And of course, the first question would be how, and that's then for the poll, we cannot make the poll now, how would you actually define extreme ischemic stroke risk subgroup? Because this is not officially not defined. And I suggest that that we would focus on particular clinical scenarios such as the breakthrough stroke. Why? Because the recurrency risk of ischemic stroke in this population is ranging between 5 and 10%, and there's no other clinical entity that has such high recurrent ischemic stroke risks. In terms of previous randomized controlled trials, you see the CHA2DS2-VASc score here. Clearly the leading is Closure AF with a CHA2DS2-VASc score of more than 5, followed by Prague, then Prevail, Option, Champion, and finally Protect AF. But in terms of ischemic stroke recurrency risk, none of these trials have numbers like 5 to 10% per year. These are the numbers at the maximal duration of follow-up, like 3 to 4 years, and the highest numbers were in Closure AF with 7.2% at 3 years, which gives an annual risk of roughly 2 to 3% per year. So if we then look at patients who suffer from a ischemic stroke despite taking DOAC due to AFib, we have quite some data available, and as you can see here, the risk is really ranging between 4 and 9% per year. And how frequent is that? We did an analysis in the Swiss Stroke Registry, and the proportion is incredibly increasing. Over the last 10 years, it increased from 10 to currently 40%. So if you look at all AFib-related stroke patients, 40% of those are currently, in the year 25, are taking regularly a DOAC therapy. So that's an unmet need. And the treatment concept that could be hypothetically useful in these patients is a dual strategy combining oral anticoagulation and percutaneous LAAC. Now, this has been actually tested, of course, not in a breakthrough stroke population, but in a population that, as you know, in the LAAC underwent surgery and had a surgical occlusion, and the critical point here is really that they had a high CHA2DS2-VASc score of more than 4, and all of these patients received continued oral anticoagulation on top of the surgical occlusion per protocol. And if we look at the adherence throughout 5 years, it's actually quite high, more than 70%. And as you can see here, the best, the pointer is not working in the green frame, the numbers of recurrent ischemic stroke were actually lowest in those patients getting both occlusion and those who were kept on oral anticoagulation. So here we get a clear insight into the potential benefit of combining both strategies. So what is known so far, not too much in the field of treatment of breakthrough stroke with percutaneous LAAC. There is one large trial mainly conducted in the Netherlands, a propensity score matched analysis where a total of 440 patients were treated with percutaneous LA occlusion, and in approximately half of the patients continued oral anticoagulation, and they were compared to a 1,200 patient large patient group that was receiving just continued DOAC therapy, and the results were quite interesting. You see the Kaplan-Meier curve that shows in orange those patients who received percutaneous LA occlusion on average 4 months after the breakthrough stroke event, and in blue you see the recurrency rate in terms of ischemic stroke in the oral anticoagulation group, and there was a significant difference. Of course, this was non-randomized propensity score-based registry, but nevertheless very interesting. And this trial that we did, a registry with 95 patients, was already presented. Now, which are the ongoing trials? The first one I like to present is the ELAACC trial that we are organizing from Bern. ELAACC means early closure of LAAC for patients with atrial fibrillation and ischemic stroke despite oral anticoagulation. This is an investigator-initiated trial that is supported mainly by the Swiss National Science Foundation, is international, multi-center, prospective, randomized, controlled, with 2 arms. We plan to enroll 480 up to 1,000 patients. Why this range? Because it has an adaptive design. After the occurrence of 50 events, we will recalculate the power, and then, depending on that, reassess the total sample size that is needed. Patients will receive, within 6 months after the qualifying breakthrough stroke, a percutaneous LA occlusion, with a continued DOAC monotherapy up from the very beginning, so no addition of antiplatelet therapy, versus continuation of direct oral anticoagulation therapy only, and the primary endpoint is at 6 to 48 months, is a composite of recurrent ischemic stroke, systemic embolism, and cardiovascular death, and imaging is done either by TE or CT at 1 to 3 months. Inclusion criteria, of course, these are patients with AFib, and they had a recent symptomatic ischemic stroke despite active and ongoing DOAC therapy, which is defined as not interrupted for more than 48 hours as per patient information. We don't measure level of DOAC therapies, that's too complex, it's a pragmatic trial. And of course the patient must qualify for an ongoing long-term DOAC therapy, so they are not, vitamin K is not allowed. Exclusion criteria, the most important is that, of course, strokes that are not suggestively of cardioembolic embolic nature are excluded, so strokes due to ipsilateral, extracranial high-degree stenosis, isolated lacunar strokes, or other well-defined stroke etiologies are excluded, and the other exclusion criteria are listed here. Also, patients with poor LV function, contraindications to TE, or severe renal impairment where DOAC therapy would not be indicated. 9 countries are participating, 45 sites, and currently we have enrollment is going very well. We have currently included 75 out of 481 patients, and it is exponentially increasing the enrollment rate as we open new sites. The other trial that is actually looking at the very same question and the PI is Xavi, is called LAAO. It's actually a very similar idea with a total of 380 patients, also randomly allocating DOAC versus DOAC plus LAO. The follow-up is at 12 months, and the primary endpoint is recurrent ischemic stroke or systemic embolism. And then the elephant in the room, of course, is the LAOS-4 trial, which is an industry-supported international multi-center prospective randomized controlled 2-arm trial where roughly 4,000 patients will be included with patients at high thromboembolic risk. Not necessarily breakthrough stroke patients, but the subgroup of the patients included will, of course, also represent breakthrough stroke patients. They will be randomly allocated to either receiving continued DOAC therapy or percutaneous LAAC with continued DOAC therapy. And as far as I am informed, the protocol also allows just DOAC monotherapy without the addition of antiplatelet therapy immediately after the procedure. And the primary endpoint is, of course, in terms of due to this very large sample size, can be afforded to look at ischemic stroke and systemic embolism only. And the inclusion criteria are AFib patients with a SHATS-VAS score of equal or more than 4, so high risk of stroke, and the patients must have been already on DOAC therapy, and excluded are patients with LAA thrombus. That's a difference to ELAACC, where we allow the procedure to be done. And of course, prior LAA occlusion, prior AST PFO occlusion, and interestingly, ablation is an exclusion criteria, because, as we learned, this would decrease the stroke risk. And this would be the poll, but we come to that at the end. So in conclusion, excessive ischemic stroke risk is observed in one specific clinical entity, and that is called breakthrough stroke patients, those suffering from AFib-related stroke despite continued DOAC therapy. It's present in more than 1/3 of all AFib-related stroke patients. The surgical ALA occlusion and continued oral anticoagulation is reducing recurrent stroke, so this dual strategy seems to make sense, and the percutaneous LA occlusion in that specific indication, breakthrough stroke patient, is feasible and safe with low stroke recurrency risk according to 2 registries, but RCTs are lacking. LAOS-4 in part tests this hypothesis, and also ELAACC and LAO. And with that, I thank you for the attention and looking forward to this.
Thank you, Lorenzo. Now we have the poll, and after that we will have the discussion, you and Ucho together. Okay, can we have the first poll?
But maybe waiting for the result of the poll, I have already a question to one of the speakers. Do you think there is a pattern of a patient that are at increased risk of breakthrough stroke? For example, patient with a previous bioprosthetic valve, mitral valve, for example, patient with a lot of smoke in the LAA. I mean, there is like a pattern of patient that you think are at higher risk but could benefit more from, or we just not for your. We cannot really select the patient. Okay. So let's go for the. There's only one answer. So what is your preferred approach for secondary prevention of stroke despite OAC?
But really the data published show that to switch to another oral anticoagulant is not effective in general. The additional LAAC closure with oral anticoagulant based on the LAAC 3, but we are speaking of surgical closure of the LAA that is not exactly the same thing, seems to be interesting.
I think there is a...
We are waiting for the LAAC 4.
Yeah. I think we can say there is a consensus for this question. Maybe we can move to the next question, maybe? Because we will get all the votes at the end.
But this is a good point for the consensus.
Everything will be
We all the community think that if a patient no responds to the anticoagulant, probably to add on top the LF atrial appendage closure is an effective solution.
What is nice also is that you close the appendage and you keep the oral anticoagulant therapy. So also it prevents device-related thrombus. It's a nice combination also from a patient perspective. And if one day the patient has to stop for any reason because it starts to bleed or something like that, you still have a protection. So I think
yes, one point that I want to address with Ugo and Lorenz is the non-adherence to the treatment for patient in DOAC that could be at the origin of the ischemic event.
Yeah. It's interesting. Only after evaluation, which makes sense, of any other causes, that's very important. And I think that it's going to be the neurologist that will send the patient. In ELAACC, also I'm in ELAACC, it's the neurologist that select the patient and send the patient to the cardiologist. Should be the same for the renal issue. I mean, it should be the nephrologist that send you the patient for this indication.
Yes, because we have to exclude the interaction with other treatment, the suspension of the oral anticoagulant, or that the ischemic events is based on a different origin, for example, peripheral vascular disease.
I will take someone random in the room. So what do you feel? If there is a stroke despite it's your regular approach to close the appendage?
Yes, I think for our practice is that we keep both, so we close the appendage and then we anticoagulate the patient, because I see it like when we give statins and ezetimibe and PSK inhibitors in patients who have high cardiovascular risk. So if there's a increased risk of thrombosis, of course we should tackle both ways. So quit the anticoagulation and close the appendage. Of course, there's a little bit of discussion regarding patients who are also at very high risk of bleeding. In that case, you're going to be probably doing tailored decision-making, keeping that in mind.
Adel, I want to ask to the speakers the comment on this point. Lorenz, what do you think on this point?
Well, of course, at the first step is always a clarification of the stroke etiology, because maybe usually not everything is known, and so you need a workup. Is it a lacunar stroke? Is it an atherosclerotic stroke with carotid stenosis? Is it a small vessel? Does the patient have small vessel disease, etc.? And then, of course, such a strategy of sending the patient to the LAAC makes absolutely no sense. But if the origin cannot be determined and it's not a lacunar stroke, so everything speaks for a cardioembolic stroke, I think it's a good option. What we see since we do the ELAACC is that it's not so infrequent that we find patients with thrombus in the LA despite DOAC, and I think these are the patients where the most benefit can be achieved. Of course, the thrombus should be distal or mid part, distal to the landing zone, and should be an inviting anatomy. But personally, I'm convinced that in these patients, you really can change the risk substantially if you do a good intervention.
Of course, I agree completely with you. The point is we have to discuss with the neurologist and to identify the mechanism of the ischemic stroke. Uccio.
Thank you. I completely agree. We needed to understand the exact mechanism of the stroke. In many cases, we find a critical carotid stenosis. So we can find anything. Another explanation, we are sure that true anticoagulant failure is correct to exclude the left atrial appendage. If I find a thrombus, it's so easy. They agree.
I would like to go to the other side and would ask the question, why are you so sure? So if there is thrombus in the LAA because of failure of oral anticoagulation, it might be a really high risk for DRT. So you don't know whether it's good to implant these people. It's technically feasible and it's possible, but you don't know whether they have a per se increased risk. And once you have a device in, you have a DRT and another stroke. So it's really important to study this.
Comment on that? No,
And
because,
then we have
the closure not only, I think, that the closure not only has, the effect of closing the appendage and maybe, control the thrombus, but also it modify the flow dynamics. So if you have like a very large atrium and a very large appendage, and the flow, like it's going into the LAA and then going out, it, kind of, alters all the dynamics. And by closing, you create a more steady and faster flow. So this can be, I don't know if Jordi is around, but in this, like super big left atriums, you see like big changes in flow dynamics. So it's not only the effect of, like the controlling the thrombus inside the appendage, but also the change in the flow dynamics that the appendage closure generates.
I'm quite sure that is the case, but it doesn't answer the question whether...
Carsten.
I completely understand what you're saying and I agree, but it doesn't tell you whether it's not patient risk per se. And even with these flow dynamics and better flow dynamics, there will be a DRT. So I think, that is really important to study it before to say, I think, because of, you know what I mean? Yeah.
I completely agree with you, but here, the advantage, it's that since, you're going to keep on, with the anticoagulant full dose, the risk of VRT, at the end, it's kind of controlled. So it's not, I would never give, in these patients, SAP, because I think that, as you said, like these patients have like a very high risk. And by giving, like the full anticoagulant, I think that the risk of VRT, it's kind of mitigated.
Just a comment. I follow you, Carsten, because just the fact that we have this discussion is because there is uncertainty. And I think it's a major failure that only 9% say we need to randomize these patients. We need to randomize. We can discuss closure AF and say it's selection bias, whatever. Then do the fucking study. We are proponents of this therapy, but it's those outside this room that needs to refer the patients for intervention. So we need to discuss what study should we do, how should we do it, how should we design it, how do we convince the community outside this room to refer patients to us.
And can I make a comment in this sense? Because, and also, just to Lorenz, because Lorenz said that we were running the LAAC study, and to get pure patients, and not biased patients, because, like the patients are sent to you, just to get the appendage closed. Because for the neurologist, It's like, and they feel that they cannot offer anything else.
Yeah.
So for them, they want, the procedure. And I completely agree, because there's no evidence and we need the data. But to find and randomize patients, it's very difficult. So that's why, after 1 year, like enrolling with, like a very, low rate, and then we decided to join efforts with, big trials like ELAACC and of course Occlusion AF, just to see, if we can get like maybe 5-6 patients a year, just to add, like this evidence. But I completely agree.
But I get your point, and it's true. It takes a long time to do these studies, and patients are not running into our offices. But if we decide that we close the appendages outside studies because we think they're better candidates, we will end up with closure AF results. And then we will sit here in 1 year and we will never do that study showing it actually works. So we have to decide in the interventional community that we do not close appendages on this indication until we have the results. Then we can also push those people sitting in the back to support us.
No, I completely agree, but I'm just telling you, I'm just trying to transmit that in this setting, it's especially difficult. For the expectations of the neurology, the patient, and it's not easy to randomize patients. I agree with you that we need to randomize, but it's not easy.
I think you are both right. You have both rights.
Adel,
when you said
we have time for
just
one question.
comment. Obviously, I completely agree with randomizing and doing additional studies. But what I don't understand is, why should we, if I play devil's advocate, why should we exclude other causes of stroke if we already include or randomize these patients in LAACC, where they just have a CHASQ-FASQ score of 4 and then get LAA closure? If a patient has a recurrent stroke, it doesn't matter. He has a high thromboembolic risk anyway. He would be a candidate for LAACC anyway. So why should we? That's sometimes difficult to find out what the cause of the recurrent stroke is. So why should we evaluate the other causes before? Obviously, you need to treat a carotid stenosis for sure. But if there's no carotid disease, then he's a good candidate for LAA closure.
Yes, I think that the neuroradiologist, the neuroimaging is helpful to understand the mechanism of stroke.
Sorry, it's a real question, but I think it's not so simple as that. We have many profiles of frail patients. What do you think about stroke repeated despite adequate anticoagulation with cancer? We don't have to treat them because whenever and whatever we do, they will have other risk to repeat strokes. So this profile of patient, I don't think that it will be benefit for them to be on trials because we will not have real response for these very difficult questions, I think.
I agree with that observation. I strongly disagree with the notion that we should put them in randomized trials. It will be like the ASAP2 trial. Nobody will include their patients. We will not have an answer, and the trial will stop at some point for futility. I appreciate the sentiment, but not every treatment strategy needs a randomized controlled trial. Breakthrough stroke is actually a guideline-supported indication for LAA clipping. Okay, you can say we don't have the data for LAA closure. We don't have the data against it either. It is strongly recommended not to start switching anticoagulation. There is no alternative therapeutic strategy. So I don't think we should do a randomized trial for this.
But it's ongoing. Huh? It's ongoing.
It will lead to nothing.
Okay, thanks. We have to go ahead with the last presentation. Okay, now we are going to touch a very important aspect. It's the patient preference. It's cited in the United States guidelines. It's not so highlighted in European. And I invite Fabrizio Ugo for the talk. Thanks, Fabrizio.
Was the poll before? This was the poll before?
There's not the poll before the presentation?
The poll before? Okay.
Or you can give it after. Don't worry.
Oh, no, as you want.
Okay, let's give it after.
As you want. After?
Yes, after.
Okay, now we speak about two topics that cannot involve in a randomized trial, clearly. Is the patient preference not to be involved in the randomized data. We cannot have
about that, so we can discuss about that only between us. And sorry for this slide, it's in Italian language, but I can translate for you. This is the first flyer that I created 12 years ago in my hospital, where I summarized the indication, a good indication to put the patient to drive to LAA closure. So the first part is here. We divide different kind of patients. So we have the patient naive, at high risk clearly. On the left, we have an high-risk patient, but naive for oral anticoagulant therapy, with contraindication to anticoagulant therapy, with a patient preference, or too sick, too diseased. As an alternative, LAA closure is an alternative to start with DOAC. They can take DOAC, and LAA closure is an alternative. On the other side, on the right, we have the patient, but they experience a failure of oral anticoagulant therapy with recurrent bleeding or stroke, and we look here the presence of also of another. The second topic is non-compliance, not adherent patients. So I include in my flow chart, in my indication 12 years ago, this kind of patient, a patient preference and non-compliance, not adherent patient. So this is the central controversy that we discuss about these two topics. Should LAA be considered in patients who are ongoing preventable risk, eligible for oral anticoagulant therapy, but unlikely to stay on oral anticoagulant therapy, and we have to select oral anticoagulant versus LAA closure. So just to share my doubt and perplexity with you, if a patient persistently refuses oral anticoagulation therapy after appropriate counseling, this is the most important point, is this patient still adequately treatable medically or effectively untreated? Should informed patient refusal ever open the door of LAA closure discussion, even in the absence of a formal bleeding contraindication? Where should we draw the line between shared decision-making and inappropriate expansion of device therapy? Because in fact, patient preference is represented by an heterogeneous group of patients who can take oral anticoagulation therapy, but who choose not to take it. So we have data about this topic. I think that we can use this trial to extrapolate the data, because in PROTECT AF, this is the result after 4 years of follow-up. We know very well the data about that. But in fact, in this trial, is randomized to oral anticoagulant therapy or LAA closure. So is the patient that we can choose the oral anticoagulant or LAA closure. We have more recent data provided by Champions AF trial, 3 years. You know very well this data, but I remember to you that this is a trial, this is a randomized trial. We follow the patient also in the arm of our oral anticoagulant therapy very close. 1 month visit. So in the arm of oral anticoagulant therapy, the address is 90%. In real life, if 50% at 3 years. This is the difference between randomized trial or registries. But in fact, we have this trial that published Roberto Galea the last year that involves, is a registry clearly, it's not a randomized trial, but involved the patient that refusing oral anticoagulation therapy. This is the flow chart, so we have a small group of patients that refuse oral anticoagulant therapy. In the other arm that we compare, we have the medical indication of LAA closure. This is a classic European indication to LAA closure. So this is the picture, the photo of the phenotype of two groups. Clearly, we have two uncomparable groups with high heterogeneity between refusal group and control group that follow the medical indication, classic indication. Younger patient is more represented in the refusal group. Clearly, the young patient don't want to take oral anticoagulant therapy long life. Completely different is the control group. Most diseased patient, look here, most hypertensive, diabetes, chronic kidney disease, expressed by CHA2DS and summarized by CHA2DS score. Look here, we have CHA2DS score is more similar to Champions AF patient for the refusal group and is higher in the control group, like to close AF trial. And look here, also regarding the bleeding, we have a low risk of bleeding in the refusal group and high risk of bleeding, or people that experience a previous bleeding is a classic indication to control group. It's not surprised that, and I will be provocative, the patient preference is better, the doctor indication, no. Clearly, is not, they are not comparable to group, very heterogeneity, but by the way, I would like to show that we don't have high events in the patient preference, despite we have high events in classic indication. This is a Champions AF patient, this is a closure AF patient. We can compare that. The second topic is adherence. Okay, no, we understand very well this problem. In randomized trial, we have 90% of adherence patients in the group of our anticoagulant therapy arm, but in real world, 50% at 3 years. And this impact clearly is a time dependent to interruption of oral anticoagulant therapy. More than 6 months, we have more events with increasing the CHA2DS score clearly. And the reason, the most important reason of not adherence of our anticoagulant therapy is provided by the fear of severe bleeding, or also different patients that had previous bleeding or fracture that don't want to take a lifelong therapy, and other reason as too much cost or different patients that take a lot of drugs in his life, they don't want to take another anticoagulant. So I can imagine the patient preference and the non-compliant as two big quadrants with a great heterogeneity inside of people. So in patient preference should not be reduced to a convenience of patient alone. In clinical practice, patient preference may reflect different conditions as a fear of bleeding, prior traumatic bleeding experience, anxiety for long-term anticoagulation, poor trust in chronic medication and refusal after counseling, and lifestyle incompatibility. For example, I'm a sport cardiologist and I follow the master athletes. Sergio, you are a real high-level biker, so I treat 2 bikers, patients, sportive athletes of 70 years, they're competitive, after fall down and femoral bone fracture. They don't want to refuse a category to take another time our anticoagulant therapy. This, for me, is a good indication, and I close 2 patients of sportive athletes, master athletes, clearly. For factors that impact of non-adherence, we have different conditions regarding the patient, the knowledge of the disease, the fear, for example, to take. We have an overlap between non-adherence and preference. Look here, the fear of bleeding, the fear to take a medication, the condition of the patient, asymptomatic patient. The patient is not acknowledged the real weight to importance to take anticoagulant therapy long life to cure his condition. Also healthcare systems and also social economic factor impact of non-adherence. So it's important to understand and to individualize the barriers to medication adherence and to overcome that. So if we want to fill these two cadres, we have different aspects, but they can they are comparable, I think, and they are matched between two different topics. And finally, there's a common final path characterized by the two groups may remain at risk and high stroke and embolism problem. So my take-home message are the patient preference and non-adherence patient should not be treated as automatic standalone indication with LAA closure. However, in carefully selected patients, I think LAA closure may be a good indication as a shared decision-making, a multidisciplinary framework. This interpretation is consistent with current guideline logic, even if it goes beyond the narrowest traditional indication boundaries. Thank you.
Thank you, Fabrizio. Now, can we start with the first poll? Yes, Fabrizio, I agree completely. The point is that the consideration is if the patient preference and how the patient preference should impact on medical decision, because it's a very critical aspect. It's a social, it's a philosophic, etc. Because the patient doesn't have all the elements for the decision, because it's a perception of dangerous therapy or discomfort therapy or the risk of a procedure, but it doesn't have all the elements for even though I think that to involve the patient in the decision is correct. Okay, can we start?
Yeah. It's not, oh, yeah, please.
Can I add
yeah, sure.
No, regarding this group of patients and what the patient wants, I think that if the trials go well, it could be a good option. But we have an important issue here because we are in the Catalyst, and the appendages that we found in the Catalyst trial patients are super difficult to treat because they are healthier patients with more contractile appendages and more lobes and more trabecula. And these are appendages that need to be treated for interventionists that are very experienced, because in the trials that we will see the results, the interventions were performed in centers with a lot of experience. So what will be the problem if the trials go well and everybody starts doing this kind of appendages, and they are very difficult ones, and this is something that needs to be super safe because it's healthy patients that have another option. So this is something that also needs to be addressed because it could be a problem for the therapy.
You mean that those populations sometimes have higher risk because they are very contractile appendage, and then if you don't give them the drug...
No. That it's difficult to close this appendage.
Okay.
So if maybe the intervention is not so skilled,
it
could be difficult. Maybe we have embolizations, maybe we have perforation, and it's very, very risky depending on the hands. If everybody starts closing appendage and healthy appendage, maybe the people will start thinking that it's very risky, and maybe the therapy just goes down. So this is something just to keep in mind also.
Good point.
Okay, do you have Adel? Do you have yes, Claudio.
Yes. Can I make a provocative comment? Maybe too much naive, but really, truly, I don't have many patients who are not adherent to the therapy. Maybe just the patient who suffer from paroxysmal atrial fibrillation. They want to have a catheter ablation because of discontinuation of anticoagulation. Really, truly, I mean, just the majority of patients follow, in our institution, really, probably 85-90% are on anticoagulation without any doubt. So I don't know where this data come from. I mean, just if you look at the randomized clinical trials, I mean, there are patients who not really adhering to the anticoagulation. So I doubt that we have so many patients who really, not, on anticoagulation all the time, and they drop maybe after 1 year, 2 years. That's not my experience.
Can I also join in this comment? So it depends also, as a doctor, what you're telling to your patient. So their choice will be mostly influenced by what you're going to tell to him. So of course, I think this we should keep in mind. So exactly, I have the same experience as you. So a lot of patients will take their pills actually.
There's a difference between refusal and non-adherence. This is something, there is an overlap, but I remember one patient that I put in the registry, this was a butcher. So he was cutting meat every day, and so he said, I cannot live with that. So sometimes, really, there's a fear about taking long-term. And it was, like you said, a low-risk patient, so close the appendage, and it was a difficult one. I remember it was super difficult.
Domenico.
So, disclosure, I'm an electrophysiologist. So I would
can you speak the microphone?
I would have liked to see a third option, that is refer the patient to catheter ablation. So I think those are like 60 to 70% of these patients are kind of a lone AF or ocean patients. So I think, and what we can do in these patients is probably in 60% of them, we can just manage with ablation, and also we take care of progression from paroxysmal to persistent and stop anticoagulation safely, and eventually in the intermediate patients consider concomitant procedures. But I think like at this point, these patients should be referred to catheter ablation, especially if they don't want to take anticoagulation.
But this is a special population of patients. The point is, if tomorrow is Saturday, next week, in your hospital, one patient with indication for the oral anticoagulant, he say you, okay, I don't want to take the anticoagulant because I am afraid of for the risk of bleedings, because I am an active sportsman and so on. What do you do?
So first of all, I consider ablation. And then based on the risk of the patient, I will go for ablation alone, and then after 2 months stop completely anticoagulation. Or if you are talking about like 3 or more of Chaz-Vasc, consider eventually concomitant procedure.
Yes, but in the real world, no one of us interrupt oral anticoagulation.
I disagree with that.
But it depends.
In a patient 1-2 Chaz-Vasc,
clearly.
after ablation.
No.
That's why I'm saying that if we start considering ablation as part of the pathway to treat these patients, because if I see like the study of Roberto, so like I see patients that have low risk, but at the same time, those are patients who are going to progress to persistent AFib if we don't take care of the arrhythmia. And so even the stroke risk is going to increase over time. And so maybe at this point we can occlude the appendage, but then these patients are going to have other comorbidities and other things, and it's going to be hard also to manage in the future. So I think as first line, starting with ablation and eventually consider concomitant.
That's a very good point. Yeah, thank you.
Can I have a comment? I'm really surprised to see 72% of us think this way, because where I feel it, I think it's important what we tell the patient, because if we agree as this is the consensus, this opens up to a large way of thinking, providing unnecessary LAs to the patients, and also in like UK National Health System, we are not able to do this. So even though there are a lot of caveats to it, but the way it is framed, I don't think this should be the consensus of the, because we have to adhere to guidelines. Guidelines are based on randomized trials and a lot of evidence. And if you try to personalize this, I think it is a big danger, in my opinion.
So we keep it aside, that it's not a consensus about this indication. Do the audience agree about that? That a patient refusal first, we need to convince the patient that it's good, or we have to send him to ablation and to cure the AF or as much as possible. Do you agree with that, or so we change a little bit the consensus here?
Yeah, or you can, Adel, you can either ask, I will close the appendage if the patient is not going to take. Because, I mean, if you know that the patient is not going to take the anticoagulant, okay, you need to advise the patient to take the anticoagulant.
Okay.
But would you prefer nothing or just closing the appendage?
Yeah.
I mean, just to pose this question, again, it's provocative, no? Because you have to, but between one or the other, that's the situation. Or nothing, and you cannot randomize those patients.
So after extensive information to the patient and still refuse something like that, okay. But the point about ablation was a very good point, I think. First, if it's a low risk that you can cure the AF, I think you should go for that first. And then we have now 2 trials showing that the risk of stroke is extremely low, so probably you don't need to close the appendage. Yeah, it's a very good point.
Yeah, 2 comments. I probably see a different patient that electrophysiologists see, because my patients are not so adherent to oral anticoagulants. It's point 1. And according to guidelines completely do not accept that there are patients who are not adherent to the therapy. Guidelines are saying that you have to push and push and push your patient to oral anticoagulants, but according to many registry studies and so on, there are 30 to 50% of patients who do not accept that, are not adherent to that therapy. And the problem is what to do with these patients. We can close the eyes and say, yeah, you should take oral anticoagulants, but these patients do not want and want next.
Yes, but in the real world, we know that more or less 30% of patients are without anticoagulant because they are not adherent. Okay, we have to move to the last because we are. No, we can jump the last. Close the session.
Yeah. Okay.
So, okay, thanks.
So it's time
to move to the last session. Thanks so much for the speakers and the audience for the interaction. And I invite Ignacio and Lorenz.